So as I walk into my patient's room, I am going to perform hand hygiene for 20 seconds. I will close the curtain, and since we're conducting this examination before Corona times, I'm just going to wear gloves as PPE. Then I will introduce myself to my patient. Hi, my name is Amanda. I'm going to be your nurse today. What is your name?
Molly.
Nice to meet you, Molly. Do you know where you are today?
In the hospital.
Do you know the year?
2020.
My patient is alert, oriented, and aware ×3, so we can move right along. So, do you take any medications at home?
No.
Do you take any herbal medications?
No.
Do you do any substances like alcohol or drugs?
No.
Do you do any exercise?
No.
And what is your definition of health?
To not get sick.
Perfect. So then I'm going to ask for my patient's permission if I can perform a head-to-toe examination. Do I have your consent?
Yep.
Perfect. So then I will start with the head and neck. And in order to do this, I will take my pen light and I will shine the light in the first eye and notice that direct constriction, and then in the second, notice that there's consensual constriction. So that is a normal finding. Then have my patient look at the pen light, and as it moves closer to her nose, the pupils should constrict and converge, which is a normal finding, and noticing that the pupils are equal, round, and reactive to light and accommodate. So that is a normal finding. Then I will assess for my patient's sclera, noticing that it's white, not discolored, and that is a normal finding. Then I will have my patient say, ah, and I will notice that her oral cavity is pink, moist, and there's no ulcers or lesions. And then I will assess for the trachea of my patient by noticing that it is midline by palpating the left and right side, and then I will assess for the carotid artery on one side to make sure that you don't occlude blood flow. Then I will assess for cranial nerve number 11, and I do this by placing my hands on my patient's shoulders and asking her to shrug against my resistance, which she does. And then I'm going to ask her to turn left and right against the resistance on my hand, which she's able to do. So she passes, and that is a normal finding. And then we are going to assess for the respiratory system. So I'm going to have my patient please stand up. And then I'm going to notice that the anterior and posterior part of the chest has a diameter of 1, and that when she turns around, that the transverse diameter is 2. So the ratio is 1 to 2, which would be normal, and if the ratio is 1 to 1, that would be indicative of a barrel chest or COPD. And now we are going to further inspect the respiratory system by noticing that my patient is not using accessory muscles to breathe, and we are going to have my patient place her arm over her chest, and we are going to count the respirations, which the normal would be 12 to 20 breaths per minute, and we notice that the chest rises and falls equally on both sides with 1 inspiration and 1 expiration. And while she's here, I'm going to take her O2 sat, so she's going to give me her finger, and the normal finding is that it is equal, greater or equal to 95%, so she is in normal range. And while we're here, we are going to then palpate for the respiratory system, and I'm going to have my patient turn around, and we are going to do the systematic chest examination. So I'm going to place, have my patient place her arms at her side, and I'm going to place my hands at T9 and T10. I'm going to instruct my patient to breathe in and breathe out, and my hand should rise and fall with her breath. So that is a normal finding. Then we're going to do the tactile pharynx test. So as I move down her spine, she's going to say 99.
99, 99, 99, 99.
And the normal finding is that the vibration is equal bilaterally on both sides. So she passes with that. And then we are going to percuss the lung field. So we do this starting on the left, and we move across, going down, across, and you do that throughout the whole back, noticing that the sound is resonance. and that is a normal finding, and you compare sides as you move down. And then the diaphragmatic excursion is the movement of the diaphragm, which should be 5 to 7 centimeters as she breathes in and exhales. So that would be a normal finding. And then we are going to auscultate. So we first have our patient turn around, and we're going to auscultate for the bronchial sounds. So we're going to do this by assessing the left and the right side of the trachea, and one expiration should be longer than one inspiration. And then we are going to assess for the bronchial vestibular sounds. So in order to do this, we're going to have my patient turn around, and we're going to assess this on the along the spine, and one inspiration should be equal to one expiration, and then we're going to assess for vestibular sounds, which are on the lateral side of our patient, where one expiration is shorter to one inspiration, so that is a normal finding. And then we are going to discuss bronchopnea. So we're going to use our scope, and we're going to instruct our patient to please say the word 99.
99, 99, 99, 99.
And the 99 should be muffled, and if the 99 is clear, that is indicative of fluid in the lungs, where we would need to consult the provider. So she is normal with that. And now we're going to move right along to the cardiac system. So I'm going to have my patient please lay down, and we are first going to inspect that the JV vein is not distended. So we're going to have our patient turn to the left, and we are going to first take our ruler and place it at the highest point of distension, and then take our other ruler and place it at the angle of Lewis, and the reading or the measurement should be less than 3 centimeters, and if it's greater than that, we can go ahead and do the hepatojugular reflex test. But since it's normal, we can move right along, and we are going to auscultate systematically. So we're going to first notice that S1 and S2 sounds are normal, and that if we hear S2, S3 and S4, that would be indicative of a murmur. But before we auscultate, we're just going to do a clean sweep of the chest, noticing that there's no heaves or lifts or any thrills. So since there is none, that is a normal finding. So now we can go ahead and auscultate. So we're going to do this first by placing our scope at the aortic, which would be on the right side of the second intercostal, and that is S2, and then we're going to move to the right, and to the left, and that would be the pulmonic, and then that would be S2, and then we're going to move one rib down, which would be on the right side, which would be the tricuspid, and then we're going to move down to the 5th or 6th intercostal space would be the mitral, and that would be S2 sounds, and also the tricuspid would be S1, and the mitral would be S1 as well. So now after auscultating, we are going to take our bell of our diaphragm and assess for the carotid artery. So we're going to have our patient look to the left, and we are going to assess the carotid for any bruits, which would be turbulent blood flow, which would be an abnormal finding, but since there's not, that's normal. Then we are going to inspect the abdomen, noticing that it is flat and round, and if it was protuberant or scaphoid, that would be abnormal, but since it is normal, we can continue on and divide the abdomen into 4 quadrants, and we are going to assess that there's also no bruises or wounds that we need to worry about. So then we're going to auscultate. We're going to first use our scope, and we're going to start in the right lower quadrant at the iliocecal valve, then we're going to move up to the right upper, then over to the left upper, and then down to the left lower. And we're going to notice for vowel sounds, and when we listen for vowel sounds, the normal range is 5 to 30 vowel sounds per minute, and we have to stay in each region for at least 5 minutes to then approach a provider to confirm that there would be no sounds. So as we continue on, we then palpate the abdomen, going in each quadrant, noticing that the sound is tympany and dullness over any organs. And then as we continue on, we can also assess for the liver and where that is located. So we could do tympany, and then once we hear dullness, we would mark that with a pen, and then we would go from the bottom up, tympany, dullness, and then mark that, and the normal would be 6 to 12 centimeters at liver size. So that would be normal. And then we are going to assess the upper extremities. So I'm going to have my patient please stand up, and we are going to first notice the skin, that it is congruent with her ethnicity, which it is, so that is a normal finding. And then we are going to assess the skin, and it's warm and dry, and then we are going to assess for the radial pulse, which would be 60 to 100 beats per minute, and that would be normal, so she is within range. And then we are going to assess for capillary refill. So this would, we would press down on the nail bed and notice that the color comes back in less than 3 seconds. And then we would test for upper extremity strength. So I'm going to have my patient grab my arms and squeeze, and she can do that, so she has strength. And then I'm going to have her move her fingers away against my resistance, which she can do, so that's great. And then we're going to also check for any clubbing, so I'm going to look at her fingers and notice that the angle is less than 160, and if it was greater, that would be a late sign of cyanosis. Then we are going to assess the lower extremities, noticing that the color is congruent with her ethnicity. We can assess the pedal pulse if need be, and noticing that the skin is dry and warm to touch. And then to check for lower extremity strength, I'm going to have my patient bend her knee and have her not move it down against my resistance, so that is a normal finding. And then we are going to move right along and assess my patient's gait. So as we do this, we are going to have my patient walk from point A to point B normally, noticing that she doesn't sidestep. And then my patient is going to walk back, doing heel to toe, noticing that it's in a straight line and that she doesn't sidestep or fall. So that is a normal finding. And then we are going to ask my patient if she has any issues urinating.
Nope.
Perfect. So now we can continue right along to the range of motion test. So we're going to do the cervical. So I'm going to have my patient flex, so tilt the head down, and then we're going to have extension, which is just neutral, and then hyperextension, we're going to flex it back, and then we're going to do lateral bend, so left and right, and then we're going to do rotation, left and right, and then we're going to do the thoracic lumbar, so we're going to flex forward, and then we're going to extend, which is neutral, hyperextension's back, lateral bend, left to right, rotation, left to right, and then we're going to do our shoulders, so we're going to put it forward, and then we're going to hyperextend it back, and then internal rotation, we're going to place our hands behind our back, and then external rotation over our head. Abduction is away, abduction is towards the midline, and then we're going to do our elbow and wrist, pronation, supination, flexion of the wrist would be down, extension is neutral, hyperextension fingers up, radial deviation pointing in, ulnar deviation pointing out, flexion of the fingers, curl in, extension, we want to spread them out, abduction, move the fingers apart, abduction, move them together. Then we're going to flex the hips, so we're going to do this by first straightening the leg out, then we're going to bend at the knee, then we're going to do external rotation, internal rotation, then we're going to do abduction, so move the leg out and then cross it over the midline for abduction. Then the knees, we're going to flex, bend at the knees, then extension, stand up tall, and then inversion, pinky toe down, eversion is the big toe down. Then the toes, you're going to first do this by, we're going to demonstrate on our hands, we're going to fan them. Flexion would be curl them in, extension would be to fan them out, abduction, fan them out, abduction, put them in, and then we're going to teach my patient about the breast examination and the importance of it. So we're first going to do it in the office, so I'm going to have my patient raise her arm over her head, and we're going to assess the breast in a circular motion, going in to out, and we're going to do this noticing if there's any lumps or bumps, dippling or rippling, or any discoloration. And we are going to look especially where the lymph nodes could be swollen or enlarged, which would be at the tail of Sven. And we are going to teach our patient the importance of this, to do it at home to prevent any breast cancer from occurring as a preventative measure. So that's really important. And so we're going to thank our patient for coming in, and that it was a pleasure to see them, and then no referrals needed because it's all normal.